Welcome to the September 2025 educational event. I'm Kavya Velagapudi, Executive Director of the Neuroendocrine Cancer Foundation.
I'm Lisa Yen, Director of Programs and Outreach.
And I'm Heather Davis, the Director of Community Engagement.
Today's presentation is on understanding alpha and the evolving PRRT landscape. A special thank you to our supporters, Novartis, Ipsen, Exelixis, Curium, Crinetics, ITM, Boehringer Ingelheim, and InterScience Institute. Neuroendocrine Cancer Foundation, previously known as LACNITS, provides a community of support and education for neuroendocrine cancer patients and caregivers. Our staff includes Lisa Yen and Heather Davis. Our board includes Donna Gavin, who is the sister of our founder, Giovanna Joyce Mbezi, and NET patient Mary Dunleavy. Neuroendocrine Cancer Foundation also partners with the Carcinoid Cancer Foundation to provide its programs, including the Luncheon with the Experts and the support line. Now I'll hand it over to Heather.
Thank you, Kavya. Our YouTube channel features over 475 educational wellness videos, testimonials, and podcasts. Click videos or playlists to find patient and caregiver stories, information on types of treatments such as PRRT, liver-directed and targeted systemic therapies, and find out more information on imaging, surgery, and our annual conferences. And you can also find our educational videos by topic in our video library on our homepage at ncf.net. Find us on social media at Facebook, X, and Instagram with the handle at NCF Cancer. And be sure to add us to your Safe Sender email list. And I'd like to remind our audience that our webinars are created for educational purposes and do not substitute as medical advice. The views shared in this webinar are from the experts' experience and insights. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it over to Lisa.
Thank you, Heather. We have seen the field of PRRT, Peptide Receptor Radionuclide Therapy, evolve rapidly, and patients are hearing more about recent developments and clinical trials. To this end, we invited medical oncologist Dr. Udhayvir Grewal to explain these advances and what they might mean for people living with neuroendocrine cancer. Dr. Grewal is a gastrointestinal and neuroendocrine tumor medical oncologist at the Winship Cancer Institute of Emory University and an assistant professor of medical oncology at the Emory University School of Medicine in Atlanta, Georgia. His research focuses on drug development and care delivery innovations for patients with neuroendocrine tumors. Dr. Grewal serves on the North American Neuroendocrine Tumor Society (NANETS) Membership and Diversity Committee and the European Neuroendocrine Tumor Society (ENETS) Grade 3 Neuroendocrine Neoplasms Task Force. At the 2024 NANETS Annual Symposium, he was honored with the Best Scientific Poster Award in Clinical Research for his poster presentation highlighting racial inequities in NET clinical trial enrollment. After medical school at Government Medical College in Punjab, India, Dr. Grewal completed his internal medicine residency at Louisiana State University Health Sciences Center, Shreveport, and a hematology medical oncology fellowship at the University of Iowa Holden Comprehensive Cancer Center, where he also remains an active collaborator with the University of Iowa NET SPORE team. I've had the pleasure of getting to know Dr. Grewal over the past couple years, and I've been impressed by his care and dedication to helping the NET patient community. Welcome, Dr. Grewal.
Hello, everyone. I'm Udhayvir Grewal. I am a GI neuroendocrine medical oncologist here at the Winship Cancer Institute of Emory University in Atlanta, Georgia. It's a pleasure to be here today. I'm thrilled to be talking about this important topic of understanding alpha and the evolving PRRT landscape. Before I dive in, I really want to talk about the classification of neuroendocrine neoplasms. NENS is this big umbrella term that includes a wide variety of neuroendocrine neoplasms, broadly categorized as well differentiated, meaning the more well behaving, less aggressive neuroendocrine tumors, and poorly differentiated or neuroendocrine carcinomas that are the more aggressive neuroendocrine neoplasms. But something important to understand here is that every patient is different and every tumor is different. This is something that I discuss with all of my patients when I see them for the first time or when I'm helping them make important decisions regarding their care. And even patients with the same type of neoplasm have very different response to therapies. So whenever I, as your medical oncologist, am recommending a particular therapy or discussing what therapy might be best for their care, it's important to take into consideration that every tumor is different, every patient is different, and this is something to be mindful of even when we talk about PRRT. Now, we've come a long way as far as the therapeutic paradigm of neuroendocrine tumors is concerned. Going back to the 1980s, we had modestly effective therapies such as streptozocin, interferon, and then the somatostatin analogs like octreotide came along, and then alkylating chemotherapy. We had targeted therapy. And it wasn't until 2018 that lutetium dotatate or Lutathera was FDA approved and was ready to be administered to patients in our clinics. In this presentation, I will be using peptide receptor radionuclide therapy, or PRRT as a term, interchangeably with radioligand therapy, or RLT. Radioligand therapy is sort of a newer term that is more inclusive of newer therapies that are similar to peptide receptor radionuclide therapy and are currently in development. So this is sort of a newer term that is being used, but for practical purposes, it means the same thing as PRRT. So, what is PRRT? Often, when I'm discussing lines of therapies or what therapies might work best for patients in clinic, PRRT obviously comes up. And the way I try to explain this to my patients is most of neuroendocrine tumors are characterized by the presence of special receptors, proteins on the cell surface called somatostatin receptors. And multiple therapies that we use for the treatment of neuroendocrine tumors, such as somatostatin analogs, octreotide, lanreotide, these are the monthly shots that most patients with advanced neuroendocrine tumors will receive at some point. These therapies go into somatostatin receptors, and once they bind to somatostatin receptors, they lead to reduced growth if their neuroendocrine tumor is producing certain substances such as hormones, etc. These therapies will also reduce the production of those substances. How is PRRT, or peptide receptor radionuclide therapy, different? It's just that what you're receiving in the shots is coupled with a radionuclide. So it's the same therapy, just coupled with a radionuclide. It goes and binds to the somatostatin receptor and it goes inside the cell, and the radionuclide separates from the shot and emits radiation, which ultimately damages the DNA and kills a cell. Why? Because these cells cannot survive without the DNA. This is how PRRT works. Now, it's not that we came up with PRRT in a few months or a few years. It was decades of work that went into the development of PRRT as a feasible therapy that could be administered to our patients. And arguably, I think this is the most significant therapeutic advancement for the management of neuroendocrine tumors. It was ultimately approved in 2018 based on the results of a crucial study, which I'm going to be talking about next. So NETTER-1 was that study, a phase 3 trial that led to the approval of Lutathera in 2018. In this study, all patients with mid-gut neuroendocrine tumors that had experienced disease progression on first-line somatostatin analog therapy were randomized to either lutetium-177 dotatate or Lutathera, or a higher dose of the somatostatin analogs. And what was found was there was an 80% reduction in the risk of disease progression with Lutathera. And there was also a significantly higher tumor shrinkage with Lutathera, which was a clear evidence of efficacy of this therapy. We also saw that Lutathera was helpful in improving the quality of life of patients across multiple domains such as physical functioning, fatigue, pain, diarrhea, etc. So it was not only that it was slowing down the progression of their neuroendocrine tumors, but it was also helping with a lot of these other symptoms that impact the quality of life of patients with neuroendocrine tumors. Now, NETTER-1 led to the FDA approval and looked at the safety and efficacy of Lutathera in mid-gut neuroendocrine tumors after patients had experienced disease progression on first-line somatostatin analogs. NETTER-2 came up with this question, hey, what if we were to give PRRT to patients that had not experienced disease progression on frontline therapy with somatostatin analogs, and we were to give this to patients with higher grade of disease? So the NETTER-2 trial was designed to look at the feasibility of administering PRRT to patients with both pancreatic as well as small bowel neuroendocrine tumors with their Ki-67 from 10 to 55%. So these were higher grade 2 as well as grade 3 gastroenteropancreatic neuroendocrine tumors that had still not experienced disease on frontline therapy with somatostatin analogs, and these were randomized to either lutetium 177 dotatate or Lutathera, or a higher dose of octreotide. And what we found that there was a significant improvement in the primary endpoint, which was progression-free survival. We saw that there was a 72% reduction in the risk of disease progression or death with lutetium 177 dotatate as compared to high-dose octreotide. So what this showed was Lutathera was actually helpful in slowing down the progression of the disease, even in patients that had not experienced disease progression on frontline therapy with somatostatin analogs, and was still very effective in patients with higher grade disease, which was higher grade 2 or grade 3. So this was a very helpful advance in the care of our patients with NETs, and showed that this is a viable therapy, this is a feasible therapy, and effective therapy. Now, this also brings us to an important question. Should this be what we offer to all our patients when they come and see us in clinic, and we're looking at what frontline therapies to choose from? And I think that even though NETTER-2 sort of alludes to the possibility of this being a feasible and effective therapy, I don't think we can still use that one-size-fits-all approach and offer Lutathera as a frontline therapy to all patients. There's still a lot of nuances to this decision making. There are some important criticisms on this trial as well, because the comparator arm was high-dose octreotide. What if I want to make a decision between chemotherapy or Lutathera for a patient with higher grade 2 or grade 3 pancreatic neuroendocrine tumor? That head-to-head comparison is still not there. And if you're going to pick Lutathera so early on the treatment course of a patient with a neuroendocrine tumor, are we going to exhaust treatment options ultimately? And is that even necessary in most patients? Can we wait for disease progression to occur on frontline therapy and eventually use Lutathera? These are important questions that still remain with NETTER-2, but nonetheless, this is an excellent study that tells you that this is an effective approach for many patients, but with careful multidisciplinary iteration. Now, what is alpha radioligand therapy, or alpha PRRT? This is a new kid on the block. We know that Lutathera is effective. It has really transformed the care of our patients with neuroendocrine tumors, but there are still those patients that we really feel the need to do better, because with the use of Lutathera in those patients, most will have disease progression within 2 years. There are also those patients where the disease burden is very high, and in sites where Lutathera may not be as effective as we would want it to be. So there is a huge unmet need to do better in those patients. So alpha radioligand therapy sort of offers an effective therapy that may open more avenues for helping those patients and improving upon the success of Lutathera. What is the difference between alpha and beta PRRT? As I discussed in the graphic, where I was talking about the mechanism of beta PRRT. These are basically just the shots that most patients will receive at some point during their care, coupled with a radionuclide substance. Now, if that radionuclide substance emits beta radiation, it is beta PRRT, which is Lutathera. But if that radionuclide substance is an alpha emitter, the therapy is referred to as alpha radioligand therapy. How are alpha and beta radiation different from each other? Alpha is supposed to have something called linear energy transfer that's higher than beta PRRT, which basically means that it delivers more energy than beta PRRT. Also, alpha causes more DNA damage. DNA is made of two strands, and beta only cuts one strand. Alpha cuts both of those strands, so it causes more pronounced DNA damage, so it has the potential to cause more tumor kill. There is also some data that suggests that alpha may cause lesser damage to normal tissue around the neuroendocrine tumor and may have less off target side effects. And beta radioligand therapy relies on the presence of oxygen around the tumor, which alpha does not. So, in theory, it is possible that alpha may be able to treat those areas of disease that we currently have a hard time treating with beta PRRT because those areas are hypoxic and just very difficult for beta PRRT to treat. So basically, alpha radioligand therapy is hypothesized to be stronger and perhaps more effective than beta PRRT. Action 1 is a phase 3 clinical trial that is looking at bringing alpha radioligand therapy to the clinic in patients with gastroenteropancreatic neuroendocrine tumor. Now, this trial is a two-part trial. It had a phase 1 that was looking at safety, and that's already done. The trial is currently in the phase 3 part, and this trial is trying to look at the efficacy of actinium-225 dotatate, or RYZ101, which is an alpha radioligand therapy product, in patients that have received Lutathera in the past, have benefited from it, and now have experienced disease progression. So we're trying to see, can we use RYZ101 or alpha radioligand therapy in these patients as the second time that they receive PRRT and get a good amount of benefit? So this trial is only accruing patients with grade 1 and grade 2 gastroenteropancreatic neuroendocrine tumors, and these are being randomized to either the treatment arm or standard of care. So what we're trying to compare is alpha radioligand therapy in these patients that have received Lutathera in the past and have now experienced disease progression better than what we have to offer based on FDA-approved standard of care therapies. In the standard of care therapy arm, there are multiple options that are available: everolimus, sunitinib, or higher dose of somatostatin analogs, which are all acceptable standard of care therapeutic options. And these patients are randomized 1:1. What's wonderful about this trial is two things. In the investigator's choice standard of care arm, it's left to the treating physician and the patient to decide what standard of care therapy is best for their care and then stick with that. And the other lovely thing about this trial is there is allowed crossover. So if you get randomized to the investigator's choice standard of care arm, then once your cancer has progressed on that therapy, you're allowed to cross over to the actinium-225 dotatate arm, which means as long as you're on this trial, at some point you will receive the RYZ101 or actinium-225 dotatate. What this trial is trying to look at is progression-free survival, which basically means, is RYZ101 better at slowing down the disease progression compared to standard of care therapies among these patients? There are other alpha agents in the pipeline, which are, as opposed to RYZ101, which is actinium-based, these are lead-based products. So lead-212 is another alpha-emitting radionuclide that is being studied in patients with neuroendocrine tumors, both that have received radioligand therapy in the past, as well as patients that have never received beta radioligand therapy in the past. There are two different products, lead-212 dotamtate, as well as lead-212 VMT alpha net. So I think this is wonderful that we're not just moving forward with the development of a single agent in this space. There are multiple agents that are being looked at. So we will have different agents to choose from, which which ones to bring to clinic, which have a better safety and efficacy profile. Now, despite the encouraging progress that we have been making in the development of alpha radioligand therapy, there are still several outstanding questions. Once we are able to bring alpha radioligand therapy to the clinic, where is it going to fit in the treatment paradigm? We have so many different options for treatment, including beta PRRT. So, where is alpha really going to fit? Is it going to be a therapeutic approach in patients that have never received PRRT first? So, this is going to be the first type of PRRT that I offer my patients? Or is this going to be a better suited therapy for patients that have already received beta PRRT in the past, and then I use this as sort of like the second time they see radioligand therapy? Then what is the safety of these newer alpha radioligand therapies in patients that have either received radioligand therapy in the past or have never received radioligand therapy? That is something that remains to be determined. We have at least 3 different products that are being developed right now and are in phase 3 trials. Do we really know, is one better than the others? They're not being compared to head in any of these ongoing trials, but this is something that we will have to determine when we are picking one over the other. And ultimately, I think what we will need is effective strategies to personalize therapies. Does everybody need alpha radioligand therapy? And can we still come up with effective strategies to choose between Lutathera and some of these newer alpha radioligand therapy? That is something that is going to be an important question to ask and come up with answers to. Ultimately, I think the big question is alpha radioligand therapy really more effective and safer than beta radioligand therapy? It sounds like it should be, but as the results of these clinical trials sort of read out, this will be an important determination to make. Are these therapies really that much better in terms of efficacy and also safety than beta radioligand therapy, which is a current standard of care? An important thing to remember here is whenever we offer radioligand therapy to patients, of course, there are some other side effects that we discuss with patients, but the big one that we worry about is long-term bone marrow toxicity. And by long-term bone marrow toxicity, I am referring to the long-term risk of bone marrow cancers, which includes myelodysplastic syndrome and acute myeloid leukemia. Now, the risk appears to be low. We know from NETTER-1 that the risk is 2%. But, I often think of this number in the sense that it looks like it's a fairly small number, but when it does occur to a patient, their risk is 100%. So I never try to minimize this risk. This is a very real problem and something we need to be mindful of as we sequence therapies, as we come up with newer radioligand therapies. This is going to be an important determination to make. What is the long-term risk of bone marrow toxicities as we develop newer radioligand therapies? This is from a study that we published in 2024, where we looked at the FDA adverse events reporting system, and we showed that the risk of MDS and AML is very real. It is a minority of the hematological toxicities of Lutathera, but that risk is still there and very real, even in the real world setting. Now, the next important question is, we've already looked at the data that led to the approval of Lutathera. We've talked about some new exciting updates in alpha radioligand therapy, some ongoing clinical trials. But the big question is, with PRRT, where does this fit in the treatment paradigm of neuroendocrine tumors? So this study is looking at lutetium edotriotide, which is just a different version of Lutathera. For practical purposes, this is a therapy that is pretty similar to the FDA-approved version, Lutathera. So COMPETE trial is an exciting phase 3 study that accrued patients with grade 1 or grade 2 neuroendocrine tumors coming from the small bowel. And they were basically trying to look at how does PRRT fare compared to everolimus in terms of slowing down the progression of disease in both patients that have experienced disease progression on frontline therapy or are treatment naive. And lutetium edotriotide is basically a different version of Lutathera. And the results were presented at ENETS earlier this year in Krakow, Poland. And what we found was the median progression-free survival was significantly longer with lutetium edotriotide, which is a type of beta PRRT, compared to everolimus. This was about 23 months with a PRRT compared to 14 months with everolimus. Now, this tells us that everolimus is still a very effective therapy, as we know, but if we use PRRT in patients that are either treatment naive or experience disease progression on frontline therapy, we're able to achieve greater suppression of disease progression with PRRT compared to everolimus. So it really adds to a growing body of evidence that with PRRT, perhaps the sooner you use the therapy, the better it is. And it's probably better to sort of keep the other therapies in the back pocket for use as later line therapy. Now, again, I'm not saying that that should be the case in all the patients that we see in clinic, but for a vast majority of patients, there seems to be good signal that PRRT as a therapy, when you look at it, if a patient is a candidate for it and is in need of some intervention in some form, using PRRT sooner rather than later is perhaps the way to go. There's another trial called the COMPOSE trial looking at the same product in patients with gastroenteric neuroendocrine tumors as well as pancreatic neuroendocrine tumors with Ki67 15 to 55%, sort of the higher grade 2, grade 3 neuroendocrine tumors. And we are trying to see if this beta PRRT is better than other therapies, not just everolimus, but also capecitabine and temozolomide, as well as Folfox, another chemotherapy combination, IV chemotherapy combination. How does PRRT do in terms of reducing the risk of progression compared to these standard of care therapies? And again, this is an exciting study, phase 3 study, still enrolling. And this trial will actually tell us that is PRRT even better than some of these other therapies like chemotherapy with capecitabine, temozolomide, Folfox, as well as everolimus. So this will sort of help us fix another piece of the puzzle in terms of sequencing of PRRT. Sometimes the term salvage PRRT can be used to describe the use of repeat PRRT in patients that have received PRRT in the past and have subsequently experienced disease progression. For as long as we've had PRRT available for treatment of patients with neuroendocrine tumors, as most of you would be aware, PRRT has been around for a while, even in clinics in European centers. It was only FDA approved in the US in 2018, but patients in European centers have been receiving this since late 90s, early 2000s. There has been interest in using PRRT as a salvage therapy in patients that have already received PRRT in the past and have experienced disease progression. And there is some limited data from European and Asian centers where it has been shown that repeat PRRT is safe and effective. And if you look at the consensus statement from NANETS, North American Neuroendocrine Tumor Society, the recommendation is that it is reasonable to consider repeat PRRT if the patient's tumor has responded well to the initial full course of lutetium dotatate. We try to look at this at the University of Iowa, which is where I did my fellowship training. And we found that patients that had received beta PRRT initially and then experienced disease progression, and at the time of progression were offered repeat PRRT, they did benefit from the therapy. The only difference is that when you do receive repeat PRRT, the progression-free survival, meaning for how long your cancer is going to benefit from it, and for how long we're going to be able to slow down disease progression, is going to be 50% compared to the initial period of time after first round of PRRT. We also did not find any new safety signals, long-term hematological as well as kidney toxicity with repeat PRRT. So this is an effective therapeutic option that we offer to a lot of our patients in the clinic, and it seems to be effective, although the efficacy does go down by 50%. So for example, if I have a patient that received PRRT, then had stable disease for about 3 years, when I offer PRRT again, as a therapeutic option in that patient, what I'm basically looking at is disease stability for a year and a half or so. Now, there are ongoing clinical trials that are prospectively evaluating the safety of repeat Lutathera in patients that have received Lutathera in the past, have had stable disease for at least 12 months, and then now have experienced disease progression. They are being randomized to another 2 cycles of lutetium dotatate versus everolimus, which is a standard of care therapy. And we're trying to see what is the benefit in terms of reduced risk of progression with repeat lutetium dotatate compared to everolimus, which is a standard of care therapy approved in this setting. Roulouth trial is a French study that is trying to evaluate a similar question, but mostly trying to answer the question whether we need another 4 cycles of Lutathera or just 2 cycles would be enough when we offer repeat PRRT to these patients. We're also trying to go beyond neuroendocrine tumors that originate in the stomach, small bowel, or pancreas, and trying to expand the indications of PRRT to lung neuroendocrine tumors. And this is an aligned study, phase 2 study, that is looking at the safety and efficacy of lutetium dotatate in patients with pulmonary neuroendocrine tumors. And this is being compared to everolimus, which is, in addition to cabozantinib, is the only other FDA-approved therapy for patients with lung neuroendocrine tumors. We now have exciting data for our patients with pheochromocytoma and paraganglioma, which was just published, I think, a couple of weeks ago in the Journal of Clinical Oncology, where we found that PRRT is an effective therapy, both in terms of reducing the risk of progression as well as causing tumor shrinkage in patients with pheochromocytoma and paraganglioma. This is sort of reflective and proof of what we have already seen in clinical practice, that this is an effective therapy for these patients. These patients should be considered for Lutathera, and this should be offered as a standard therapy to these patients. Now, another interesting concept with PRRT, we've looked at, beta PRRT, using beta PRRT again. We've looked at using beta PRRT in sort of other neuroendocrine tumors coming from the lung. And we've also looked at alpha radioligand therapy, which is an exciting advancement and update in the field. In addition to all of these advances, there's interest in combining PRRT with other agents to sort of build upon the therapeutic efficacy of PRRT. In one of the initial slides, we looked at the mechanism of how PRRT works. I talked about PRRT sort of causing DNA damage, and that's how it is able to cause tumor kill. Now, the principle is, can we combine PRRT with another agent that will help it cause more DNA damage and more tumor kill, and can we use this strategy to sort of get more benefit out of PRRT? There are several trials ongoing that are either looking at agents that cause DNA damage or sensitize the cancer cells to damage from the radiation in PRRT. Can we use other NET therapies, or can we use immunotherapy, or can we use different types of radioligand therapy and combine them together to basically get more tumor kill and build upon the therapeutic efficacy of PRRT? And I think this is another exciting sort of avenue for us to squeeze out as much benefit out of PRRT as possible. I quickly wanted to also talk about PPQ and NET test, especially NET test. A few of my patients have brought up the question whether or not NET testing that we should be offering and considering for their care. PPQ and NET test sort of are both blood-based assays where we are looking at the expression of certain genes that are relevant to neuroendocrine tumors. And what we're trying to do is come up with predictive biomarkers to see who are these patients who are more likely to benefit from PRRT and who are these patients who are less likely to benefit from PRRT. PPQ is a test that is done before patients undergo PRRT, and it tells you whether a patient's tumor is likely to respond to PRRT or not. And NET test is sort of a more temporally assessed biomarker, sort of like a tumor marker like CA19-9 or CEA in other GI cancers. NET test is done at multiple time points as the patient receives PRRT, and it has been shown that as net test starts increasing in value, that corresponds to lesser benefit or lack of response to PRRT. And as we see a decrease in the net test value, the response to PRRT. Now, these are being looked at. There are some existing studies that have looked at this. I know the NET-RETREAT trial does have net tests incorporated. So as we build more prospective data, we will be able to answer the question of whether these biomarkers are ready for prime time. But at this time, we don't have enough data to support the use of these biomarkers in clinical practice. There's also this question about dual tracer imaging, and a few of my patients have asked me in clinic, hey doc, how about we get the other type of PET scan? And the other type of PET scan is FDG PET-CT, which is more commonly used in other types of more aggressive cancers. Now, the more commonly done PET scan is somatostatin receptor PET, gallium-68 DOTA-TOC or DOTA-TATE PET scan, copper-64 DOTA-TATE PET scan, which is done to assess the expression of somatostatin receptors in patients with neuroendocrine tumors, especially prior to them undergoing therapy with PRRT. There's a lot of good data that shows that if the cancer is very bright on the DOTA PET and not bright on the FDG PET scan, then the likelihood of benefit from PRRT is higher. But if we see that the cancer is sort of not as bright on the DOTA PET and is brighter on the FDG PET, then the likelihood of benefit from PRRT is lower. So again, this is sort of a work in progress. I do use this in certain situations, certain clinical scenarios, but still something that's not ready for use in all patients that are undergoing PRRT. Again, I do want to take some time here to highlight that with all these rapid advances, all these new clinical trials, exciting new avenues building upon the success of radioligand therapies in neuroendocrine tumors, the importance of multidisciplinary management is becoming more and more relevant. And there are multiple providers that if you are seeking care at a NET center, you will be in touch with at some point during your care, be it medical oncologists, surgical oncologists, nuclear medicine physicians, endocrinologists, pathologists, radiologists, and interventional radiologists. These physicians will reconvene as appropriate and discuss important points related to your case, need for particular therapies, at what point should a particular therapy be used, and should PRRT be used first or some other targeted therapies, or a particular clinical trial be better, or would sort of a surgical approach be better? So it's important for multidisciplinary approach to be a key component of the care of any patient with neuroendocrine tumors, not just those undergoing or considering undergoing therapy with PRRT. I do want to highlight that with all these advances, new exciting opportunities to bring these novel radioligand therapies, alpha radioligand therapies, new combination strategies, using PRRT for more and more patients with neuroendocrine tumors and developing biomarkers to sort of personalize these therapies. It's also important for us to make sure that this progress is equitable, that we are able to bring these clinical trials and these newer therapies to each and every patient that needs and deserves high quality, high class care for their diagnosis of neuroendocrine tumors. So it is a responsibility of investigators, pharmaceutical companies, of institutions, of patient advocates, and all of us together who are involved in the care of patients with neuroendocrine tumors to make sure that this progress is as equitable as possible. And before I end my discussion for today, I would like to acknowledge my amazing Emory neuroendocrine tumor team. And so I did my fellowship training at University of Iowa. So I would like to acknowledge our wonderful University of Iowa neuroendocrine tumor SPORE team for their guidance. I wouldn't be here without their help and support. Thank you.
Thank you, Dr. Grewal, for a fantastic overview on the current landscape of PRRT, including alpha PRRT. That was really phenomenal, and I know that myself and others probably are looking forward to rewatching it and pausing and taking in all the information. And also thank you for your permission to share the slides, which we'll share later on our website. as well. So just as a reminder for our audience that this question and answer session is for educational purposes only. It does not substitute for medical advice. Please talk to your medical team with questions or concerns about your individual care or treatment. You deserve that individualized care. And we do have over 26 questions. We're going to try to get to as many general questions on this topic as possible on PRRT. And please note that we will address broad-based questions only, and Dr. Grewal cannot provide specific feedback on your specific situation. So Dr. Grewal, thank you and welcome back for our live question and answer session.
Thank you so much, Lisa. It's an honor to be here. Thanks for this wonderful opportunity.
Well, we really appreciate you, the work you've done in this area, the recent review article that you wrote and published as well. And so I think the very first question we should get to, just the big elephant in the room, multiple people ask this in many different ways, is when might alpha therapy be widely available outside of clinical trials for patients?
Yeah, that's a great question. A lot of my patients have brought this up during their clinic visits with me. As I discussed in my presentation, there are a few products that are currently in clinical trials. The big one is actinium-225 dotatate, and then there are other lead-based products. So Action 1 recently concluded accrual. So it's going to be another couple of years till we get the results, and then we finally have the results available. So it'll be another few years until an alpha product might be available for use in clinic. But until then, we will have clinical trials in some form looking at alpha radioligand therapy in different treatment settings. So until this becomes an approved therapy available for use in clinic, we will be relying on clinical trials for offering alpha radioligand therapy to patients.
Okay, thank you for that. As you know, not everyone tunes in from within North America. In the UK, alpha PRRT is promoted by practitioners not licensed in the UK, so patients might be going overseas, Germany, India, to name a couple places, with the support of their UK consultants. So is the US another option for UK patients to obtain alpha PRRT?
Lisa, even before social media became a thing, I think PRRT was the net social media, was bringing everybody together sort of on a global level. A lot of our patients from the US were going to European centers to get PRRT before it obtained regulatory approval in 2018. So I would say that option still exists, and this is something that can be offered to patients here if in the US, if the same is not available in their countries. But I do know that there are so many other countries that have alpha radioligand therapy available. If this is something that is felt necessary for their care, and they're able to obtain all the resources, put together all the resources that are needed for being accrued onto a clinical trial or getting access to alpha radioligand therapy. Otherwise, I think this is certainly an option for sure.
Okay. Yeah, thank you for that. And I don't know if you touched on this in your presentation. Is alpha PRRT with antagonist radionuclide currently in clinical trials or treatments in the US or the EU? And I think this person specifically was asking about neuroendocrine lung carcinoid with mild SSTR expression. But could you also explain what antagonist therapy is?
Yeah, that's a great question. There has been an interest in antagonists like SSTR antagonists for a while. And if you look at Lutathera or even like the alpha products that are currently in clinical trials, they basically are somatostatin receptor agonists, meaning they go and bind to active somatostatin receptors. But antagonists do not care about the active state of the receptor, so they bind to both the active as well as inactive state of the somatostatin receptor. In preclinical models, somatostatin receptor antagonists have shown to have higher sort of uptake in net cells. But there have been some early phase clinical trials looking at these products. There was a study done at Sloan Kettering, but I think the toxicity was a big concern with the antagonists, and that has probably been a hindrance in their development. And I don't know of any big clinical trials that are currently looking at that. It's mostly the agonists that have picked up and gone on to phase 3 studies. As far as the question for lung neuroendocrine tumors is concerned, that is a real problem. If you look at the data, in all comers patient population with lung neuroendocrine tumors, about 30 to 40% patients may have homogeneous somatostatin receptor expression, and many others may either lack somatostatin receptor expression or may have spotty somatostatin receptor expression, meaning when I do a PET scan, I see some patchy light up, and then there are areas that are not lighting up, meaning they don't have somatostatin receptor expression. So that is a key impediment in the use of radioligand therapy or PRRT. And if I have a patient where the scan does not show that their cancer lights up bright enough, and by enough, I mean I'm making comparisons either with how bright their spleen is looking or the rest of their liver is looking. This is something called the Krenning score. If that expression is not high enough, I know that PRRT is not going to be as effective as we would want it to be. So this is one of the things that we look at when we are planning the use of radioligand therapy or PRRT. And if the cancer is not lighting up bright enough, unfortunately, that I would say PRRT is not going to be as effective as you would want it to be.
Thank you. When we talk about lighting up and such, there's actually a question that may be related to this. Do SUV values correlate with the degree of success for PRRT treatments?
There's no right or wrong answer to that. As a general gestalt, I would say yes, the brighter the better. But I don't think we have come up with a particular threshold that, okay, if it's above this value, I mean, I've heard so many different thresholds during tumor board discussions from various nuclear medicine physicians. We have used, of course, a Krenning score in the past. So I think that is sort of more like a crude way of quantifying somatostatin receptor expression on these functional imaging scans like DOTA PETs. But I think when you look at SUV, I think if it's like as low as like 1 or 2 or 3, it's like pretty low expression. Of course, we know that PRRT may not be effective, especially in those areas with low somatostatin receptor expression. But overall, I think I usually don't rely on just a hard number to decide whether or not PRRT is something worth considering.
Okay, thank you for that. There's a lot of questions about side effects, and I know you touched on this a little bit in your presentation. Could you highlight the differences in side effects between the traditional PRRT, the beta PRRT, and alpha? And what would you expect the gap to be between rounds of alpha PRRT?
Yeah, that's a $1 million question, right? I mean, when we look at a new therapy, it brings new hope, it brings also new challenges. New hope because we are hoping that this is going to be a very effective therapy. It is going to build upon the success of Lutathera and offer more effective PRRT therapy with durable responses, better responses than beta PRRT. But then there's also this question, is it also going to bring along with it more toxicity? Now, we don't have the results of these ongoing clinical trials available, but the big concern is renal toxicity and long-term bone marrow toxicity. So there have been some reports, I cannot go into the details, but some reports about patients having kidney toxicity or renal toxicity. And then as we, spending more time with alpha radioligand therapy, with the long-term safety data from these ongoing clinical trials, we will know if there is a significant increase in bone marrow toxicity as well, meaning long-term risk of myelodysplastic syndrome or acute myeloid leukemia. There are also some other toxicities like gastrointestinal toxicities, like swallowing difficulties with some products. So it's not just the more traditional bone marrow toxicity or kidney toxicity, but also some other unique toxicities such as gastrointestinal toxicities. So it'll be interesting to see what the safety events look like, what the safety data looks like. But for now, these agents are in clinical trials, and it's important to consider that, we still do not have reliable safety data for these products.
And when do you think that safety data might be available to us?
One of the trials is finished accrual. It'll be another maybe 2 years or so till we get concrete long-term safety data. So it'll be another couple of years until we can have a full report of long-term safety data. I often tell my patients, in neuroendocrine tumors, most of the cancers are relatively slower growing. So because of that, the results of the clinical trials are also going to take some time to come out. The other thing is we're not just looking at safety data over 6 months or 1 year. We're looking at safety data over a couple years or even beyond, because that is going to be something that we're going to be looking at even in real world. We don't want our patients to live safer for another just 12 months. We're looking at many years of good quality of life, free of any toxic side effects associated with these therapies.
Yeah, thank you. So it takes a couple years for that information to come out. Okay.
Correct.
Well, it's like you read people's minds, because there was a question about the kidney toxicity. So I'll read it out. And there's a part of it that maybe you could follow up on. There are concerns about greater kidney toxicity with alpha. Are these fears supported by trial data? And I know you already addressed this. And are there new amino acids or other kidney protections available to less toxicity risks or lessen toxicity risks?
I've already alluded to this. There are some concerns for high-grade kidney toxicity events. And for as long as we've been working with PRRT, we've used amino acids and hydration to sort of allay this kidney toxicity. I don't know of any new amino acid formulations that have come up, but one of the alpha products, the VMT AlphaNet, has a special linker molecule that is hypothesized to help improve the renal safety of the compound. So we're hoping that this would probably be milder on the kidneys and there will be less kidney toxicity events with this product. But again, we don't know if that's going to be the case. We're hoping for that, but we don't know yet. So there are novel strategies. I'm glad that that is being considered as we are developing these newer agents to develop safer agents, not just more effective therapies. But I'm not aware of any newer amino acids being administered to reduce the renal toxicity of these agents.
Thank you. You also mentioned the bone marrow toxicity. There was this question that is related. Will PRRT treatment ever be available without the small yet very real risk of myelodysplastic syndrome or AML as a side effect?
That's the dream. I would love to have a therapy that has zero long-term hematological toxicities. But I know there is a lot of interest in personalizing the use of therapies. I think the first question is determining the risk. Like I said in my presentation, this 2% number can be very misleading, because I remember a couple of my patients going through that when they developed therapy-related MDS and AML. The risk for them is 100%. It affects their life 100%. So I think the first step is to identify or come up with strategies to better predict who are these patients who are going to develop long-term hematological toxicities. And one of the concepts is using something called CHIP, or clonal hematopoiesis of indeterminate potential. And this is basically doing a liquid biopsy on your blood, or also doing a bone marrow biopsy and then running some molecular testing on the bone marrow biopsy and identifying the presence of some of these unique clonal mutations. And it seems like these clonal mutations, when they're already present before administration of the PRRT, they sort of predispose patients to development of these long-term hematological toxicities like MDS and AML. So if we can prove that in a well-done study and sort of develop ways to identify who these patients are going to be, who are going to develop these long-term hematological toxicities, and then give them just the right amount of PRRT that they need, which is going to be safe and effective, I think that will probably be as close as we can perhaps get to minimizing the risk of long-term hematological toxicities. I don't think we're ever going to have a product that is going to have zero long-term hematological toxicity, unfortunately.
I love the idea of personalizing it, knowing what your risks are, and then be able to make that personalized decision based on that.
Right.
And thank you for sharing about your patients and what that journey is like. Even if it's a low risk, that it's 100% for those people who experience it. That's very real. And somewhat related, and perhaps that CHIP testing will help, is there a lifetime maximum of PRRT?
That's a great question. If you look at retrospective data, the Netherlands, there is data on even repeat PRRT. So per Netter 1, most patients, when they first get Lutathera, they will get 4 cycles of Lutathera, each 2 months apart. So that's 4 treatments of Lutathera. And then we monitor for disease progression with scans. Then, when the cancer starts progressing and to the point where it needs intervention, and we discuss all the available treatment options at that point, and if we think that PRRT is the best therapy to go ahead with, then we offer something called repeat PRRT if you're talking about Lutathera. I typically like to limit that to just 2 treatments. And if there is further progression in the future, you can again consider 2 more. But honestly, I've only done that for 1 patient so far, and I am a little hesitant in going for that 3rd round. So I think I try to limit it to just 2 instances of treatment. First with 4 treatments, and then when you get repeat treatment, then you get 2 treatments of Lutathera. And I think that's pretty much it. There are some centers that offer repeat 4 cycles, but I think we don't have the data to actually support that those 4 cycles are needed. The ReLuth trial, which is being done in France, is exactly looking at that question. And once we have the results available, we will know if those additional 2 cycles are going to offer benefit in the repeat PRRT setting as well.
Okay. And you mentioned also in that context of the repeat PRT that the efficacy goes down when it's repeated, about 50%.
Right.
Why does that go down? And if it does go down, is it worth repeating it? Or when is it worth repeating PRT?
Right. So I think the reason why it goes down is because when we first offer PRRT, the expression of somatostatin receptors is pretty high. Eventually, there might be some reduction in somatostatin receptor expression. Also, when the cancer progresses after PRRT, it also develops some resistance mechanisms to sort of evade the effects of the radiation from the PRRT. So it's a combination of all these events, how many somatostatin receptors are available, and how resistant is the neuroendocrine tumor to radiation. Now, when I'm looking at whether or not to put repeat PRRT on the table, I'm looking at for how long did the initial PRRT treatment work? And as you said, data from University of Iowa as well as other European centers, they have consistently shown that the benefit sort of is reduced by 50%. So if your cancer was stable for about 3 years or so after first round of PRRT, I think we're looking at about a year and a half with the second go of PRRT or round of PRRT. So I personally like to see 12 months of disease stability after initial use of PRRT. So I'm looking at about 6 months-ish of benefit with repeat PRRT. And again, to bring up your initial question of like, how many cycles would you go for in the repeat PRRT setting? We know that when you give 4 cycles of PRRT, with the first 2, the benefit is the maximum. And after the second treatment cycle, the receptor expression drops significantly. So how many receptors you had at the very beginning, it's about 60-70% of that is already done after second cycle of PRRT. So I think you get the most benefit from the first 2 treatment cycles. So when I offer repeat PRRT, I'm looking for 12 months of disease stability with first round of PRRT, and I only offer 2 cycles.
Yeah. Okay. So at least 12 months. And if someone responded well the first time, then you're really considering it. You talked a bit about measuring, the clinical trial data and what the measurements are in the trials. Can you explain why progression-free survival is measured as the endpoint in the clinical trials for neuroendocrine tumors? And is overall survival ever measured in these trials?
That's a $1 million question. For a lot of the other clinical trials done in other cancers, overall survival is a gold standard for demonstrating the effectiveness of cancer therapies. The idea is if a therapy really does help patients live longer and better, then it is effective. If it merely just slows down the progression of the cancer without helping people live longer and better, then it is really not making a meaningful impact on the lives of patients. Now, this gets very nuanced when you talk about patients with neuroendocrine tumors. These are unique tumors. If you compare it with like pancreatic cancer, patients live for maybe a year, a little more than that in all comers patient population in the advanced setting. But with patients with pancreatic neuroendocrine tumors or small bowel neuroendocrine tumors, we're looking at a few years or many years. And I have patients who've lived decades with their diagnosis and undergone many treatments. So when you're looking at the effectiveness of therapies in a slow growing tumor, it's really hard to look at overall survival because these patients are going to live for a long period of time. So it's also impossible to design clinical trials that are powered to look at that, like improvement in overall survival. The other challenge with using overall survival as an endpoint in clinical trials is a lot of our patients, when they do receive PRRT or any other therapy that is being looked at in the clinical trial, if they were in the control arm, they will eventually get that therapy at some point, either off of that clinical trial or in that clinical trial with crossover. So whether you were in the control arm or in the treatment arm, you did receive the therapy at the end of the day. So you can't really assess an improvement in overall survival because everybody's getting that therapy. So, because of these multiple reasons, progression free survival has been adopted as an acceptable endpoint in clinical trials with neuroendocrine tumors, and it is considered as a marker or surrogate of overall survival. So, we know that if the cancer progression is being slowed down, the patient's quality of life is getting better or maintained, and they're able to live longer.
Okay, thank you for that explanation. I think it can be confusing, especially because it is different from other cancers. Well, there's a lot of curiosity about beta PRRT versus alpha, so we'll delve into a few questions related to this. Okay, so one question is, are you seeing any difference between the PRRT naive and previous beta PRRT now receiving alpha?
That's a great question. It's very hard for me to say anything about this definitively because we don't have reliable data to say one way or the other. Anything that I say is, completely anecdotal, but I have seen a couple patients with like dramatic responses when they received alpha PRRT as a first PRRT that their cancer was exposed to, which is something that I typically don't see with beta PRRT, especially in small bowel neuroendocrine tumors. I don't think I have seen that in patients that have previously received beta PRRT and then received alpha PRRT. But it'll be important for us to wait for the results of ongoing clinical trials to see how many patients had complete responses, partial responses, or just stable disease, and for how long that clinical benefit was maintained for, meaning how durable those responses were.
Yeah. And I think the question too is, does it work better as a frontline or after the beta PRRT?
Again, this is one of the questions that I highlighted as an outstanding question in my presentation. We have the action one that is looking at use of alpha radioligand therapy in patients that have previously received Lutathera and then have experienced disease progression. We also have other lead-based products that are being investigated in both patients that have received PRRT as well as those with PRRT naive disease, meaning they've not received PRRT in any form. So once the results of these clinical trials become available, we will be able to at least, within the limitations of cross-trial comparison, sort of get a sense of how effective is alpha in PRRT naive versus PRRT pre-treated disease. But again, that will be within the limitations of cross-trial comparisons. We don't have any ongoing studies that are looking at this particular question in the same clinical trial.
Okay, so we're all on the same page with the same questions. What about the inflammation that happens? This person's asking, is alpha PRRT expected to cause inflammation similar to beta? So this person has a high risk for beta PRRT because their tumors fully encase a major blood vessel with risk of ischemia. Would this also be a similar risk for alpha?
That's an interesting question. I've never had that challenge where I'm in patients with a lot of liver disease burden. I worry about sort of the off-target side effects. I guess that is what the person who asked this question is alluding to, the off-target effects of the radiation. That is hypothesized to be lower with alpha radioligand therapy or alpha PRRT because it's very targeted in how the radiation is delivered compared to beta PRRT. But again, in the absence of actual safety data on the risk of complications associated with radioligand therapy in particular clinical scenarios, it's really challenging for me to be able to say if alpha is truly going to be better than beta. But I will say, though, this is as a clinical concern is really not a huge concern. And more studies have shown that these concerns, like, there's a study from Mayo Clinic that showed that even with patients that have very high liver tumor burden, you can safely use beta PRRT, and there are no major liver toxic events that occur with the use of PRRT. So I think in majority of those cases, the concern is more theoretical, and the physicians are just trying to be safe and prevent those future side effects. But we don't have convincing data that those side effects actually do occur that often.
What about the use of alpha PRT for bone mets? Would it be safe? Would you also use it? I'm assuming this person has more than just in the bones, but including in the bones, would it also be safe?
Right. Again, with the absence of data from clinical trials, it's hard to say how safe PRRT, alpha PRRT is going to be for patients with bony metastases. I will say the risk of hematological toxicities with PRRT in patients with bony metastases is very heterogeneous, and it varies with the burden of bone metastases. There are some patients that have a few bony mets, and there are patients that have very significant bony metastatic disease burden, a lot of bony metastases. And in my experience, I have had some challenges with blood counts, most notably, anemia and low platelet count in patients with very heavy bony metastatic disease burden. So that does become a challenge. But again, that risk is very heterogeneous, and you can't say it is, true for all patients with bony metastases. It truly does depend on the extent of the involvement of the skeletal system. Like I said in my presentation, the hypothesis is that the off-target side effects with alpha PRRT may actually be a little lower than beta PRRT. So theoretically, perhaps, but we will have to see the readout of these ongoing clinical trials to determine the safety and efficacy in all comers as well as subgroups of patients based on where their disease is primarily located.
Yeah, and speaking of side effects, again, does age have anything to do with it? For example, are people over the age of 70 more likely to have side effects following PRT, like lingering low hemoglobin levels or anemia?
That's an excellent question, and something that comes up, as we are, involved in the care of older patients with neuroendocrine tumors. As you grow older, your bone marrow reserve reduces. Now, this age may be their 60s, 70s, 80s, depending upon the patient. But as a rule of thumb, as the older you grow, the bone marrow reserve sort of shrinks with time. So the ability of your bone marrow to sort of take on these therapies and maintain blood counts will also decline as you grow older. But with that said, we have data, retrospective data in older patients, as we know that a lot of our older patients may not be well represented on clinical trials. So we rely on real world data to actually determine how safe and effective our therapies are in older patients. There was a paper I recall that Dr. Tom Otricio was a part of, and they looked at patients in their 80s and beyond and looked at the safety and efficacy of PRRT in those patients, and they did find that it was safe and effective in those patients. But I will say the older you get, the higher the rate of hematological toxicities would be. And this is true for long-term hematological toxicities as well. We know that the risk of MDS and AML is higher in older patients because the older you grow, the more mutations your bone marrow DNA is going to carry. So exposure to radiation may just trigger more changes and increase the risk of long-term hematological toxicities. But again, I don't think that age will be in the mid 60s or 70s, perhaps like 80s, late 80s, perhaps that risk may be higher, but we don't have any concrete prospective data to support this.
Thank you for clarifying this. Another safety-related question. There are several alpha-emitting isotopes in different studies. Each isotope has its own set of alpha, beta, and gamma decays. For example, actinium-225 gives off 4 alphas and a couple betas, one very high energy. How are the safety profiles being estimated?
I think that's a very tough nuclear medicine / physics question. I don't know if we have such sophisticated data available just yet. And a lot of these data that are looking at radiation biology and radiation physics are mostly preclinical and early phase data that is not published to my knowledge. But I think what we will have ultimately available is the safety and efficacy data of individual products like actinium-225 and then lead-212 based. I don't think such niche and precise data is going to be available in terms of safety and efficacy.
Okay, thank you. You mentioned the combination trials. Which PRRT combo trials are showing promise?
Yes, that's another exciting frontier in PRRT. I know that the triapine study, we might have some results soon. And there was some data from UCSF where they showed PRRT with pembrolizumab. I don't think pembrolizumab adds that much to PRRT, so I'm not sure how that is being developed further. There's also some preliminary data on a special drug called PARP inhibitor that inhibits DNA repair. So the hypothesis is that it is going to accentuate DNA damage with PRRT. Again, I don't think that strategy was, per preliminary data at NANETS, that strategy was effective in everybody, but it was probably limited to a certain subgroup of patients. So we don't have any concrete data on combination trials just yet, but I think we might have something coming up early next year, I think with the triapine study.
We look forward to hearing that. You mentioned the PARP inhibitor. Someone specifically asked what your thoughts were about the alpha PRRT plus PARP inhibitor.
Yeah, of course, I would not use it in clinic sort of off-label for patients with neuroendocrine tumors for the simple reason that we know that PRRT by itself is an effective therapy. So I would obviously offer PRRT by itself as an effective therapy. And for me to be convinced to use PARP inhibitor in combination with PRRT, I have to have convincing data on safety and efficacy. There was something presented at NANETS from NCI. And I think the data showed that there is no added benefit in an all-comers patient population, but in a subgroup of patient population with certain mutations, there may be some efficacy. Now, PARP inhibitor works at the level of DNA repair. So perhaps if your cancer is affected by the presence of an underlying germline mutation that interferes with DNA repair, and PARP inhibitor sort of adds tumor kill by inhibiting that DNA repair further, there I think there might be some activity, but there's no reliable data to support the use of PARP inhibitor with PRRT just yet.
Thank you for clarifying. So this is a good question because it has to do with grade 3 NET. What trials or other availability is there for alpha radioligand therapy or PRRT for patients with grade 3 pancreatic NET? And can you explain why this applies to questions about clinical trial enrollment?
Absolutely. There's a real unmet need in grade 3 neuroendocrine tumors. This is a newer category of neuroendocrine tumors. When NETTER-1 was done, this was not even a category of well-differentiated grade 3 neuroendocrine tumors. And NETTER-2 is the first trial that actually looked at sort of prospectively enrolled grade 3 neuroendocrine tumors, well-differentiated, both small bowel as well as pancreatic NETs. Now, as far as alpha is concerned, Action 1, of course, did not enroll patients that had grade 3 disease. It was only grade 1 and 2. But to my knowledge, one of the lead products, when I was treating patients at University of Iowa, we had the opportunity to accrue patients with grade 3 disease on the trial with the lead-212 VMT alpha net. So I'm not sure exactly how the accrual strategy is for grade 3 neuroendocrine tumor patients on those clinical trials, but there certainly is interest in accruing those patients onto these trials with the lead-based products. And I think this is really important because we need to generate more data and prospective data on the safety and efficacy of these therapies in grade 3 neuroendocrine tumor patients, which is such a new and heterogeneous clinical pathological entity.
Yeah. Can you also clarify, some people, have a surgery or a biopsy done and their Ki-67 is in the grade 1 to 2 range, so it's less than 20%. And then later on, they might have another biopsy and now it's over 20%, so grade 3 range. Would they then be going by their first pathology with the grade 1 or 2, or by the most recent one, grade 3, in terms of qualifications for clinical trials?
This is the bane of my existence as a physician treating patients with neuroendocrine tumors. I think Ki-67 is a great marker, but we need to, at some point, start thinking how we can grow beyond Ki-67. It's such a confusing thing. And just 1 or 2% change can affect chances of accrual onto clinical trials, which means which can have huge implications on the care of patients. Now, as far as like comparing two biopsies is concerned, I think in most scenarios, the higher Ki-67 is taken into consideration, whether or not it came first or later on. Once you have a few Ki-67s associated with your diagnosis, the highest one is what is going to be used to make the diagnosis, say, grade 1 versus grade 2 versus grade 3. What is the exact clinical implication of this remains unknown. Of course, if there was such a huge difference that if one of the liver metastases was 30% and then a couple others were like 12% or 10%, that's a big difference. But if it was like more like 30%, then 27%, and then 25%, their Ki-67 really doesn't make a huge difference. But to answer your question, I would say the higher Ki-67 is usually paid attention to. And I also want to highlight here that the way Ki-67 is assessed can be different at various institutions. There can be pathologists who just provide a visual estimate. There are pathologists who provide sort of an automated or digital estimate. And most pathologists look at certain hotspots on the slides, but there's also newer data coming out showing promise in like looking at the entire slide and not just some hotspots. So there are some nuances into how Ki-67 is interpreted, which is very evident in clinic when we have patients come from other institutions and their pathology slides are reviewed by expert pathologists at our institution, and the Ki-67 sort of changes over time.
Yeah, thank you. Thanks for just explaining that there are differences as well. This is a good question. What is a complete or partial response to alpha or beta mean versus the progression-free survival in terms of a number of months? Like, is there a correlation? Like, if someone has a great response, they're going to have a longer progression-free survival? That's how I read this question.
Right. I think these are two different things. A response is something that's very different from progression-free survival. Just to make this easier to understand, if you compare pancreatic neuroendocrine tumors to small bowel neuroendocrine tumors, you will see greater responses with pancreatic neuroendocrine tumors, meaning you'll see more tumor shrinkage with PRRT in pancreatic neuroendocrine tumors. But if you look at for how long the cancer remains stable, it'll be better for small bowel neuroendocrine tumors. So I'm not saying that there's no clinical relevance of tumor shrinkage. Of course, it's something that is always exciting, and we're always hoping for tumor shrinkage in all patients. But it is more likely to occur in pancreatic nets with PRRT compared to small bowel. But for how long that clinical benefit is maintained is progression-free survival. So even though small bowel neuroendocrine tumors may not have as much tumor shrinkage with PRRT, the clinical benefit over time, even if it is just disease stability, tends to be longer. So these are two separate things. They're sort of like independent.
Thank you for that. This is not exactly a PRRT question, but I think it makes sense to ask this. I'm very interested to hear Dr. Grewal's thoughts on where surgery fits in with all these medical treatments and whether the balance is shifting away from surgery.
That's a wonderful question. I have worked with some of the best net surgeons in the country, and I am a big believer in the role of surgical cytoreduction in the care of patients with neuroendocrine tumors. And if I had to rephrase that, I would say carefully selected patient population of patients with neuroendocrine tumors. I think the big challenge with surgery has been the lack of prospective clinical data. A lot of the studies from European centers and from prominent surgical centers in the US, such as University of Iowa, Mayo Clinic, MD Anderson, etc. These have been retrospective studies. We know people who treat neuroendocrine tumors on a daily basis. We know how beneficial surgical cytoreduction has been for patients with NETs. But the lack of prospective data has been one of the challenges in sort of convincing everybody of the benefit of neuroendocrine tumors, and also surgeons who specialize in the care of patients with neuroendocrine tumors are such a rare breed of surgeons, and not every institution has the luxury of having a person who is well versed with the care of patients with NETs and can actually come up with the appropriate treatment plan, can perform these surgeries. So a lot of patients, they don't even get to have these discussions at a time where they would benefit from these therapies. Now, to answer the second part of the question, whether the balance is shifting away from surgery, I would say not really. At least at my current institution, Emory University, and my prior institution, University of Iowa, and I know at many other centers where there are prominent NET surgeons, they are very well a part of the care team, where discussions are had at every step of the way. Whenever there's a need for intervention, surgery is always brought on the table, and to determine whether or not the patient is a candidate for surgery and whether or not surgery is going to have a meaningful impact on the care of the patients with NETs. But I think as we move forward, we really should be thinking about doing more and more clinical trials with surgical cytoreduction to actually demonstrate benefit in sort of a prospective fashion, to make this more of a evidence-based standard of care treatment option for patients with NETs.
So still very much, even in light of all the exciting advances, surgery is still on the table for sure. So if we can just end with this last question, this is a big one. Many questions actually related to this. How would you advise patients what the next best treatment is for them, specifically when to have alpha, if they've already had lutetium-177 PRRT? Also, if a clinical trial is on the table, how does someone get into a clinical trial?
That's a great question again. I tell my patients that when we're making decisions on what therapies to choose and what therapies would be most appropriate for their care, there's not one thing that we're looking at. We're looking at so many different things. Prior therapies that have been used already, how much benefit did they get from that? We're looking at the grade, we're looking at where all the disease is present in the body, what is the disease burden, how quickly has the cancer been progressing, which alludes to the biology of the disease. And I think perhaps this is one of the most important determinants in the choice of the therapy. Then we look at somatostatin receptor expression, and we look at presence or absence of symptoms, etc. A lot of these things go into the decision making when we are looking at whether or not a particular therapy is appropriate or not for patients. Now, when I specifically talk about alpha PRRT, I talk to them about the theoretical rationale for alpha PRRT, but I also offer some caution that there is still on clinical trials for a reason. We are trying to determine the safety and efficacy of these therapies. All that glitters is not gold. So if for some reason you are not able to get alpha radioligand therapy on a clinical trial, or your care team determines that that perhaps may not be the best option for you, that doesn't mean that we're taking away an effective therapy from you, because we really don't have the data yet to say that this is better than beta radioligand therapy. It remains to be determined, and that is our hope, but we don't have that data yet. And for many patients with, say, a grade 1 small bowel neuroendocrine tumor that had 4 years of disease stability with lutetium-177 or Lutathera, and now has disease progression, and we're looking at radioligand therapy, we may still be able to get 2+ years of benefit with 2 cycles of Lutathera. And I don't think alpha is necessarily the way to go. We will, once we have the results of these clinical trials such as Action 1 available, but right now we don't know that. So again, to make that point, you shouldn't feel like an effective therapy is being kept from you. We just don't have that data yet. The biology, somatostatin receptor expression, prior therapies, presence or absence of symptoms, etc. All of these are important parameters to take into consideration when making these decisions. It can't be just one thing that we look at.
Yeah. We really want to thank you for all your time and for your thorough presentation, thoughtful responses, and your dedication and hard work to bring more therapy treatment options to the forefront so that they're available for neuroendocrine cancer patients, so that there's more hope. So we really thank you for being here with us today and all your time and hard work on behalf of neuroendocrine cancer patients.
Thank you so much for having me, Lisa, and rest of the team at Neuroendocrine Cancer Foundation. This is what makes doing what we do every day worthwhile, just engaging with patients and working with excellent folks like you are doing so much for the field. It is an honor and privilege to be here. Thank you so much for this opportunity.
Well, people like you who are putting in all the hard work, both in the clinic and doing the research and clinical trials, you give us hope. So thank you for that hope. And with that, I'm going to turn it back to Heather in the studio. Thank you so much.
Thank you again, Dr. Grewal, for your informative presentation and for clarifying the evolving PRRT landscape. We appreciate our supporters, Novartis, Ipsen, Exelixis, Curium, Crinetics, ITM, Boehringer Ingelheim, and Inner Science Institute. Educational programs like today's are also made possible by donors like you. Please consider making a donation today at NCF/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high-quality broadcast production. Again, today's presentation and Q&A session have been recorded and can be viewed on our website and YouTube channel shortly after this broadcast. To receive reminders and newsletters, be sure to add events@ncf.net to your Safe Center contacts and whitelist email. Again, follow us on social media to stay up to date on our upcoming events. Our handle is @NCF Cancer. And now I'll turn it back over to Lisa.
Thank you, Heather. The Neuroendocrine Cancer Foundation is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, ncf.net. We offer a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our podcast page to check out the episode transcript, resources, and the questions we ask the expert. Thank you for joining us today. Goodbye, and we look forward to seeing you at our next event.